Good afternoon and good morning, and welcome to the second episode of 2024 edition of the talk show Let's Talk Primary Healthcare. My name is Gian Matteo Apuzzo, and I'm Technical Officer at the WHO European Center in Almaty related to primary healthcare. What's the topic of today? Today we are going to speak about person-centered care. Why this topic? This is a concept that has assumed a pivotal role in healthcare design and delivery. And individual needs of citizens and needs of patients are, of course, a crucial and fundamental pillar of primary healthcare. But the concept is so wide that sometimes is used as a slogan, as an empty slogan, and we risk to deviating for concrete and tangible scenarios and practices. So our aim today is to give you some example of successfully how to transform this vision into action, and how to pass from theoretically concept to tangible practice. And in the coming hour, we will navigate in the complexity of the topic of person-centered care. And we will do it thanks also to the presence of four great speakers that will help us and guide us through questions around the concept. How we can elaborate the concept of person-centered care, what are the challenges in delivering person-centered care, and what are the experiences that we can share to give examples of successfully person-centered care. After this hour, I invite you to join the breakout rooms. There will be one in English and one in Russian. And in the meanwhile, I invite you to say hello in the chat, and also to share comments, questions in the chat, and our colleagues will share some useful link in the chat. So let's go to introduce our great panel. I would like to say that I'm really delighted for the presence of the four speakers, and I welcome you, and I introduce the four speakers. Today we have Claudia Luati, Head of Policy, European Patient Forum. Welcome, Claudia. We have Juan Mezic, Professor of Psychiatry and Global Health, Icahn School of Medicine and South Mount Sinai, New York, and Secretary General, International College of Person-Centered Medicine. Welcome, Juan.
Good morning.
Then we have Karina Danta, CEO of Shine to Europe, Chair of the Cost Action Net for Age Friendly, a co-director of Schafe Foundation, Smart, Healthy, Age-Friendly Environment. Welcome, Karina. And finally, we have Carlo Rotelli, that is Senior Primary Healthcare Physician at the Health Authority of Trieste and Gorizia, Italy. So thank you for accepting our invitation, and welcome again. Let's go to the first round of our discussion, that is about understanding the concept and approach of person-centered care. And let me start with Juan Mezic. Juan, as I said earlier, it's a pivotal and crucial concept in healthcare delivery and designing. But there are many overlapping concepts, and maybe we have sometimes some confusion about all these concepts. You have just published a book on person-centered medicine, among others, scholars and editors. So can you introduce us in the concept of person-centered care?
Sure. I will try by saying that I agree that these various concepts are diverse. However, they are convergent, and they each apport a particular angle that is helpful for fuller understanding. In a more conceptual way, I would say that person-centered medicine and person-centered care represents an attempt to place the person, the whole person, at the center of the concept of health first, and then also as the center and the protagonist of the health actions. In a clinical arena, we could say also that person-centered care represents an attempt to have care and medicine of the person, of the totality of the person, by the person, by health professionals extending themselves as full human beings and technically, professionally competent for the person to contribute to the fulfillment of the goals of the person. And last but not least, with the person, in respectful collaboration with people who present and request help. In a more perhaps scientific manner, we could say that person-centered medicine looks at its task as informed by evidence, scientific evidence, but also by experience and values. So these various viewpoints, I think, can be helpful to have a fuller understanding of what person-centered care and person-centered medicine may be, in addition to other views that I'm sure that our colleagues will share with us.
Thank you. Thank you very much, Juan. And thank you also for introducing the concept of experiences. And let's go to have the perspective of patients. I will give the floor to Claudia. Of course, Claudia, your organization is very much involved with other organizations in not just defining this concept, but in the real practice of person-centered care. If the healthcare should be person-centered, of course, we have to focus on the needs, on the circumstances, and also on the preferences of patients and citizens. So can you just help us in explore what are the expectations of people?
Yes, thank you very much, Matteo, and good morning, good afternoon to everybody online. So indeed, I think person-centered care really starts with access to safe, high-quality, appropriate services and support. This is really the basis to ensure patients' trust and to improve health outcomes and to improve healthcare systems as well. As primary care is the entry point into the healthcare system, it really will shape patients' experiences. So, as you said, Matteo, the basis of the definition of patient-centered care is respect for patients' unique needs, preferences, and autonomy. Patients want to be seen as more than just their diseases. They have aspirations, they have different needs, and the healthcare system needs to ensure that these needs are met. So that means that services are not only developed for individuals and populations, but really with and through individuals and populations. And the aim is really to empower patients, to go beyond expectations, but really empower patients and increase their capacity to take care of themselves, of course, in partnership with professionals, and to achieve together the goals that they have set for themselves. So that leads me to really the concept of patient empowerment, which is at the core of what EPF stands for. So it's really about making sure that individuals can manage their own health. And that's a vital component of healthcare, and that they have the tools that they need to effectively manage their own condition and address the day-to-day challenges related to their symptoms, to attending visits, managing their diet, their physical activity. Those are all things that patients have to manage themselves. And of course, the healthcare system needs to support that. As Juan was saying before, this also relates to shared decision-making. Patients want to be involved in the decisions that affect them and in ensuring that the treatments and the care that is provided actually addresses their needs. So there needs to be mechanisms in place to ensure that patients are heard and that they have the ability to express themselves and to express these needs. I cannot talk about empowerment without mentioning health literacy, which is also really a key concept and something that patients very much want. We believe at EPF that all patients, no matter their condition, their background, their nationality, have a fundamental and legitimate right to access high quality, objective and unbiased information about their health, about the treatments, about the different options that are available to them. And that information must be of high quality and must be accessible. And of course, when it's developed with patients, it ensures that the information actually addresses their needs. And empowerment is not just about becoming an educated patient. It's really a fundamental tool, which, this knowledge and competence gained through health literacy can really can help patients achieve those objectives. So we believe, that empowered patients actually contribute to better healthcare outcomes and better healthcare systems.
Thank you very much, Claudia. And I think that this was a clear vision of the multidimensional and comprehensive approach that we need. And speaking about multidimensional, let's pass on age-friendly environment. Karina, you have a great experience on that, and I'm happy that we met several times in the past working on that. But my question for you is about challenges, because age-friendly environment is one of the fields most advanced in developing, designing and developing intervention, focus on person and through the life course and focusing on the most vulnerable ones. But yeah, when we speak about implementation, what are the challenges and the barriers in implementation?
Good morning or good afternoon. Thank you, Gianmatteo, for the kind invitation to be here. So it is true that we now have this nice introduction to person-centered healthcare, and also to what citizens need to fulfill that. But in some cases, we still have the same challenges, I fear, that we had a few years ago. I think it was around 2020, and due to the pandemic, that around the working group of SHAFE, we discussed two main challenges, which were cooperation and implementation. And I do think that on the side of knowledge and awareness, we are much better than we were some years ago. So indeed, people are aware of the need to involve patients, for example, of involving different stakeholders, of trying to understand what are the needs and put forward more bottom-up approaches. But these two challenges of cooperation and implementation, I still think lag as the big ones, and are still not fully addressed, mainly because we always seem to be dealing with emergencies. The health system in general is always with the most prominent fire to take down. And although the conscience of having more person-centered health exists, then it seems like resources are never enough to put it together. So these two big challenges were concerned on one side to have more people understanding the need to put healthcare coordinated with social care, with the implementation of digital infrastructures, with urban planning and public buildings. This on one side, still lagging behind. And then implementation, where we actually can bring more pilot actions that will promote person-centered care into real life. So instead of just having beautiful concepts in our heads, that we can actually take them down and put them in action in our daily lives. And this is still maybe not at the pace that we would want to, but we keep the hope to the future. And discussions like today, I'm sure, help to synchronize us all into that need.
Thank you, Karina, and I like very much the optimistic vision that we are more advanced than some years ago. And yeah, I think that speaking about implementation, we are really interested to listen to the vision of a physician working on primary care, like Carlo Rotelli. And my question for Carlo is about the institutions, organization dealing with primary health care. So in your experience, in your institution in Trieste, how a primary care institution should change roles, visions, and also implementation and intervention based on a person-centered care approach?
Nice to meet you, all of you. And in my workplace, I've experienced an important organizational cultural change, which have taken some years. In fact, in my primary healthcare service in Trieste, in Italy, a cultural transformation project has been carried out with a transition from a model centered on the organization and its needs, like timetables, procedures, or personnel availability and resource in general, to one person-centered. Simply speaking, the person-centered model we try to practice here includes listening, understanding, empowering, and treating the patients with a singular and tailored approach. This is generally true in the relationship with every citizen, but in particular, this is particularly true in the management of the most complex situations. But to modify the general approach of the primary healthcare workers toward a person-centered one, we have to practice a continuous effort. So we have had a gradual cultural change in some years. In our experience, we have understood that in addition to formal training opportunities, to achieve this goal, it is essential to have a continuous relationship between service managers and the healthcare workers, which means those in direct contact with the patients. We consider the nurses in first instance, but certainly also the doctors, and don't forget the office staff. So we're talking about a general orientation dictated by the leadership, exposed by the mid-level managers and transferred to healthcare staff, keeping in mind the service mission we must provide to all the citizens. So the citizen patient becomes central if the healthcare worker assumes a position of listening and service, having clear that the patient's subjectivity and needs are the focus of the relationship. To encourage this person-centered model, the manager of the primary care unit have worked day by day on the field for discussion with nurses to help the implementation of treatment plans of the most complex cases, and adopting a behavior oriented to stewardship rather than hierarchy, putting ourselves at the service of the healthcare workers, allowed us to be credible in asking staff for the necessary change toward a person-centered approach.
Thank you very much, Carlo. I think that is really interesting, your vision that I shared, that when you have this cultural shift to person-centered care approach, is all the stuff related to a healthcare institution that has to have this cultural shift, including administrative stuff. So it's really interesting what you said. Let's go into the second round of discussion, that is understanding beyond the concept, understanding the practices and the impact. And I would like to keep speaking with you, Carlo, in relation to the experience in Trieste. I think that the experience that is related to community responsiveness, and community responsiveness is one of the pillars of person-centered care. The experience in Trieste permitted to provide also evidence-based impact on health outcomes for the citizen. So can you just explain us briefly the experience and also the health outcomes that you had in Trieste?
Yes, since 2006 in Trieste, which is a northeastern Italian city where I live and work as a primary care doctor, we have started an healthcare project working accordingly to a community and person-centered healthcare model. We have adopted over 10 city areas that are particularly disadvantaged from a social and health point of view, statistically known not only for high consumption of drugs, diagnostics, and hospitalization, but also for social frailty and advanced age of the population. These urban areas were called micro areas because each one was limited in size to a maximum of 2,000 inhabitants. And in every one, we have placed one healthcare worker with the mission of working full-time every day in direct contact with the community. This healthcare worker, generally a nurse, have oriented the work of the local primary healthcare unit and the social services together, and have pulled on initiatives directed to improve the collective health and social quality. The effort within the micro areas has led to multiple effects. The overall health level of the community has improved, and the awareness of the community about their rights has increased. Furthermore, primary healthcare workers have begun to think about their mission in terms of person-centered healthcare and have understood its importance in daily practice. The results of this experimental project are statistically demonstrated and represented by a significant and sometimes dramatic decline in healthcare consumption, particularly in terms of hospitalization rate. This outcome measure is true both in absolute terms and when compared to that of the general city population. On the other hand, we have data describing social inclusion, the perceived quality service, and the safety generated within the population. In fact, a retrospective study conducted by a team of epidemiologists and sociologists is available and freely downloadable from Medline PubMed database.
Thank you, Carlo. And as I said before, we are posting some links in the chat. So for the audience, look at the chat and find the links to this document. So thank you for this vision. And when we speak about multi-sectoral, multidimensional, let's go back to age-friendly environment. Karina, in your experience, I think that is really interesting how is a challenge, as you said, the implementation of these practices, but maybe even more challenging is to evaluate the impact. So can you give us some example of tools and also experience on measurement and evaluation of a smart, healthy, age-friendly environment?
Yes, actually, I think in all of the methods or approaches that are more holistic or more comprehensive, we always have this difficulty of finding a way to measure impact because health outcomes are already so big to measure. But if you go to different areas, such as putting together the environment, the social care as well, the digital part, then it becomes really complicated. So for some time, the full network has been trying to develop and then assess some innovative methods, let's say, to evaluate this impact. And for example, I can mention the PHC. It's, I think, now in the chat box as well. This has been mostly developed, led by my dear colleague Willeke van Stagwinnen from Academy and the co-director of the Chafe Foundation. And the idea here was to pick up on a previous model that was developed around 2014, I think, which was the CIET, but now putting it together for all of the different dimensions of Chafe. So in truth, this is kind of a complex, but at the same time, easy to follow method that tries to understand the different parts of smart, healthy, inclusive environments, can be applied to citizens of all ages and also in different geographical settings, for example, for local, regional, national, or international interventions. And then we go in the impact assessment through a cycle of phases. So we go through the aim, the scope, the assessment, analysis, and results. And then the main part, I think, and which aligns a little bit with what Claudia from EPF already mentioned, is that we start the process by bringing into the assessment team different representatives of the different stakeholders in the process. So this means, of course, bringing citizens, patients, but also to bring in the healthcare professionals, the managers, the social care professionals as well, policymakers, regulators, I mean, whoever is applicable to that specific setting. And then we try to identify social, economic, and environmental impacts and link them, of course, also to different initiatives, policies, or projects. And for each of this impact, we then try to understand if the direction, negative, positive, or neutral, what was the intensity of the impact, and then also try to monetize or quantify these impacts to then do a thorough analysis, and be able to also provide back to policymakers, to public authorities, what was the overall impact of that initiative, and if some decision can be taken to, for example, upscale it or discard it. Because at the end, this part of understanding if it is worth more investment and if this is a good pathway to follow is probably one of the main wishes we have for any impact assessment, is that good things can be upscaled and those which are not working, unfortunately, get discarded.
Yeah. Thank you, Karina. That is also important to stress, as you said, that if we speak about person-centered and inclusion of people in the healthcare, has to be considered from the very beginning, from the design until the measurement evaluation. That is really important. So, Claudia, Karina mentioned you, and I would like to speak with you about the measurement evaluation of person-centered care. Quoting the OECD Patient Reporting Indicator Survey, that is one of the most important surveys about person-centered care. And most recently, publication presents results that fit very well in the discussion today. Just to mention a couple of results, there are that people who rate the quality of their primary care highly feel healthier, even when living with multiple chronic conditions. And also patients who stay with their doctor for longer periods tend to trust them more and feel the care they receive is higher quality. Therefore, quality of care and continuity of relation patient-doctor seem like a crucial element in the patient experience. Can you share with us your thoughts about that and the experience of your associations?
Yes, thank you. First, maybe just a word about the Paris survey, because it's quite an interesting initiative, actually. You know, there are a lot of different ways of measuring the performance of healthcare systems, but usually they're not very patient-centered. So it's really an initiative here to measure what's important to patients and really measure healthcare through patients' eyes. And I think it's hoped at least that it will lead to some changes in the healthcare systems and more patient-centered approaches to evaluation of healthcare systems. So back to your question, you know, indeed, on the continuity of care, this is very much aligned with our priorities and with what we've heard, you know, from our members. They constantly raise the lack of coordination in care. So patients often report that they have to fight the system in order to get the care that they need. They feel that a holistic approach to their care is missing, and that each specialist is often just looking at their own field, and that you know, this overarching coordination is lacking. So it really relates to the importance of integration of care and the importance as well of the patient-doctor relationship, as you were mentioning. In our view, this is a key factor in patient empowerment. We had a campaign around that in 2016, and this really came out that, you know, healthcare professionals are the most important point of contact between patients and the system, and a trusted relationship is very important. And I really liked Carlo's example, you know, of how this was implemented in Trieste, because really it's about creating an enabling healthcare environment for the patients, and that requires some training as well of healthcare professionals. They have to be trained in shared decision making and in communicating effectively with patients about different choices and building also their health literacy. At the moment, I do have to mention, you know, there are a lot of staff shortages. The healthcare workforce is really suffering in many places, and I think this really impacts the ability of healthcare professionals to engage with their patients, and that's something that needs to be addressed. So, as you say, you know, this two-way relationship cannot happen if doctors are changing all the time, if patients have to repeat their medical history again and again. It decreases the trust in the healthcare system. So we do really promote an approach that's based on one trusted health professional that is responsible for this coordination. I saw in the chat just a comment on digital, and we believe that, of course, AI digital tools can help transfer information, ensure that the data is passed on. But at the moment, we see them as supporting rather really than replacing this important relationship.
Thank you, Claudia, and thank you also for mentioning trust. I remind that our previous episode was on trust, so have a look at that when you can. That was really interesting. Going back to Juan, so you also, your group of scholars has developed a measurement tool. It is a person-centered medicine index that is included in the book recently published. It's interesting because it includes 8 items and 33 sub-items. So it's really a multidimensional index. Can you explain us a bit, Juan, and if there is already any implementation of this measurement tool?
Yes, thank you for the opportunity to explain this approach to measurement, which was based on a study sponsored by several international institutions such as the World Medical Association, the International Council of Nurses, the World Health Organization, to conduct a systematic assessment and conceptualization of person-centered care, and to develop measures for validation and advancement in the direction of person-centered care. This set of studies involve 4 methodological elements. One was systematic and critical reviews of the literature. Second, consultations with broad international panels of professionals, patients, and families. Third, discussions among the main research group, and statistical processing of the information, which led to first the identification of 8 principles or pillars of person-centered care, which were first ethical commitment, second holistic framework for understanding and actions, fourth cultural sensitivity and responsiveness, fifth, organization of care in a personalized manner, then sixth, the establishment of a common ground as a key element of person-centered care that led to the conduction of diagnosis as a joint understanding of the situation and health actions based on shared decision-making. The seventh was the persons and community-based organization of health services. And last but not least, the person-centered education, both professional and public education, and research, health research as well, which led, as you mentioned, to 8 pillars, and the sub-items of this amounted to 33 of them for the person-centered care index. This instrument has started to be not only validated, it has already been validated and published, but has been also used, for example, in the Latin American Network for Person-Centered Medicine. There are studies conducted in Lima, Peru, to assess and appraise prototype hospitals in Lima. So we are very excited about the possibilities of using this instrument more widely and comparing experiences.
Thank you very much, Juan. Thank you very much. It's really interesting. And for us, is also, we are delighted that we can open the discussion also to other regions, let's say not just the WHO European region, but to other parts of the world. And thank you for bringing us this experience. Going to the third round of discussion, I would like to focus on empowerment. We have spoken about the concept to the practice, but yeah, we have already mentioned enabling people, empowering people. And also in this case, there are overlapping concepts like health literacy, like participation, empowerment, user-friendly communication, user-friendly solution. It's really important to understand better what does it mean to involve citizens and patients in healthcare processes, but also in innovation processes. That is really important. And for example, about literacy, the already mentioned OECD survey reports that over 40% of respondents do not feel confident in managing their own health and well-being. I would like to explore with Claudia. I know that you are really engaged in inclusion of patients in innovation processes. So what is your experience and what you can share with us?
Indeed, and I think this reflects a broader consensus, at least an emerging consensus, that patients actually bring value, and engaging patients throughout the life cycle of medical products actually leads to better research and better health outcomes. Of course, still today, there are many trials that don't focus on research questions, or that don't measure always the outcomes that are relevant to patients. But I think a lot of progress has been made in embedding the patient voice in medical products research and development. So that goes really from the priority setting stage, so addressing, addressing the unmet medical needs of the patients, all the way to obviously clinical research. So, for example, engaging patients and patient organizations in developing consent forms, developing information for patients on the medical products that are being considered, as well as through the post-approval, the regulatory approval first, and then the post-approval of medical products, involving patients in regulatory decision-making and in health technology assessment as well. And we believe, that this leads actually to better decisions and ensuring that the products that actually bring the best value to patients are being considered fairly. And one way, that we're pushing for this more patient-centered innovation is through patient experience data. And we believe that those data actually bring a lot of information that is relevant, beyond what is usually measured as part of clinical trials. And they should be included at all stages of medical development and regulatory decision-making. So what are patient experience data? And I believe so EPF has published recently an op-ed on this topic. So please do have a look. These data are collected to describe patients' experience of their health status, of their symptoms, disease course, their treatment preferences as well. And they measure issues such as the quality of life or the impacts of the treatment on everyday life. So examples of such data include, for example, patient preference studies, large patient surveys, or impacts that are captured in registries. And really, this ensures that we're not only measuring, traditional clinical outcomes, but that also the impact of the treatment on patients' quality of life is being considered. The EMA is doing quite a lot of work in this area. There's a reflection paper that is currently being drafted on how to include that data in the regulatory decision making, and I think that will give a good signal also to manufacturers and to developers that this data is important and should be collected. So just to conclude on this, FPF was also part of a project. This is not only related to medicines, but to medical devices as well. We're part of a project called CoreMD, In that context, we had a little focus group of patients from different disease areas, and we asked them, what are the patient-reported outcome measures that matter to you? What are the impacts, that you'd like to see being measured and being taken into account as you develop medical devices and as you choose devices for your care? And then, of course, concerns related to device safety, performance, functions, but also how the device fits into their lifestyle. So this is really an emerging area, and I believe that much more can be done in order to ensure that actually medical products meet patients' needs as defined by the patients.
Thank you very much, Claudia. And it's really interesting, your publication on that. I had the chance to read it, and I invite you all to read it, because it's really, really interesting. And let me say also some, in a sense, also innovative related to other content that we can find. Going to social innovation, Carlo, let's speak about the experience interest that we can define a learning community, I think. So in this learning communities, how does the relation citizen healthcare professional change?
Yes, in our experience, particularly in the micro areas project, as you already said, we have verified the transformation of the therapeutic relationship when the healthcare workers were close to the community, using a person-centered working style. In singular cases, in particular in the most complex we have faced, we have evaluated the personal situation and needs using a person-centered approach, and we have discussed and tailored the further diagnostical and therapeutical option, and the most patients have perceived the difference. So we realized plans of care that include health and personal needs, social and familiar instances, with the help of the community as much as possible. This working style has often, but not always, proven to be a key element to a successful and satisfying care relationship. But on the other hand, the outcome on the community of the community-oriented work was truly surprising. The efforts to enhance the culture of empowerment of the communities have generated a strong participation of the most socially active part of the citizenship, previously closed and refractory. In all the community in which we have worked, the response has always been difficult and suspicious in the very first period, and never become lively or enthusiastic. We have almost always worked to connect the active parts of the community around self-help and mutual help projects in safeguarding the health of the population, obtaining a response that exceeded the expectation. Finally, let's not forget the favorable effects on the primary care operators, and an important work has been done on doctors and nurses to encourage a transformation in behavior to bring them closer to a person-centered practice. Also, in this case, we initially recorded a certain resistance to changes, and some elements left the service as opposed to the ongoing transformation. But subsequently, the results obtained contributed to change the thinking of even the most skeptical workers.
Thank you very much, Carlo. And when we speak about empowerment, we do not think just to citizens and patients, but of course we have to think to healthcare professionals. And Juan, the International College of Person-Centered Medicine had developed also a training course, a training curricula. And I would like you to share with us this experience, who are the participants, and how is going with this training course.
Thank you, Matteo. Yes, we have published our educational program under the title of Seeking the Person at the Center of Medicine, and which reviews the different aspects of this educational program. This has been followed by more specific approaches trying to link principles to strategies, particularly clinical strategies, and then in various areas of clinical medicine and public health. And more recently, we are developing workshops trying to address not only the knowledge needed to understand these concepts and procedures, but also practice to be able to have some experience about how to conduct critical elements of the person-centered care process, particularly one on person-centered diagnosis seen as a joint understanding by professionals, patients, and family of the clinical situation that is being faced. And second, the joint take of therapeutic decisions by all involved, again, professionals, patients, and families. And this has led to learning more about the importance of appropriate interaction among all of these participants in the clinical care process.
Thank you very much. I think it is really interesting. I would love to know a bit more further after the talk show about the inclusive diagnosis. I think it's really interesting concept. And going to Karina, enabling has been one of the most recognized principle, also stated by the Health Foundation some years ago, among the principle of person-centered care. I know that you recently participated in a European project called Ideal that has developed a toolkit for digital health literacy. Can you share with us some insight from this project?
Yes, thank you, Gianmatteo. I have been involved as an ethics expert in that project, and it's really interesting to see how things need to be put in place if we want to actually have a full strategy that enables digital health literacy. On one side, because of everything that my dear colleague panelists already referred, because you need to put a lot of people into the equation. So of course, this means that a strategy needs to consider all of these aspects. And for example, in the IDEAL project, you were referring to a number of different recommendations, calls to action, or specific issues that need to be considered are targeted to different stakeholders. This is one important thing because we don't have messages that fit everyone. Things that policymakers should be aware of are, of course, different from things that healthcare professionals need to be aware of, etc. But then on the side of the patient or the citizen in general, because this also calls for prevention, so I like a bit more the concept of citizen in the daily life or people. There is this big, at this point, I think, burden on having to understand on one side more about health, because you need health literacy to make decisions, to understand diagnosis, to participate in them, to know what medication to take if you don't have quick access to a healthcare professional. So there's a lot of small things that you should be aware of. But then you also have digital coming into the equation, and this brought an added layer of complexity. So now you not only need to know enough to navigate the health system, to understand any small decisions you need to take, but then you also need to navigate through difficult, sometimes very difficult digital tools. So all of this layer of complexity can be wonderful because, for example, if you are tech savvy and literate enough, then it's much easier, for example, to contact your GP through an email than to go in person. But it can also be a burden for people who are in more vulnerable situations, for people who don't have this enough literacy of both of these aspects to respond. And I think we need to be very careful about how we approach this, because the system is only as strong as the weakest link. So if we don't have a system that is actually good enough for people in more vulnerable situations, then it's not working. And all of us know that at this point, the people in more vulnerable situations very often do not have the correct access to digital health tools or to the health system in general. So it's very good that, for example, in this project, we got to engage, I think, around 1,400 people in co-creating the strategy. And I do hope that member states then pick a bit on it and take advantage of these efforts to put more actions in place that can actually empower especially those who are most in need.
Thank you. Thank you very much, Karina. And this permits me to go to the last round of discussion. We are just running a bit out of time, so I ask to my panelists to be just a bit shorter in the last answers. And I keep speaking with you, Karina, because I would like to explore now how this person-centered care approach can have a system impact. Because sometimes we relate the concept only to primary health care, because of course it's related to the healthcare provision more closer to the citizens. But yeah, it could be a concept that can change a cultural shift, as Carlos said, the entire health system. Age-friendly environment, we have said that is a multidimensional and also multi-sectoral approach. So how can be organized this multi-sectoral approach, starting from primary care, but in a vision of comprehensive healthcare provision?
Yeah, I think mostly what we should consider is to design a system that can start from each of us. So instead of having, for example, a healthcare system built starting on primary care, then let's start it on the person, on each of us. So what do you need? You should have a clear road of what to access instead of having an entry point where you are forced to be compressed depending on each moment. So I do think that even if we discuss this for some time, the health system, the whole, I don't think only the health, but the whole system is not still considered in this way. But this should be how it would go. You should understand enough of the system, know how to navigate it, and use it to your own comfort and needs every time you go through. For this, definitely we need to make it less Kafkanian, so less complicated, less burden, less administrative, and we need to have professionals and policymakers that understand the need to make it accessible, simple, and easy to go through from one place to the other. For this, I truly think that people need to have more knowledge, have more participation in society, and help shape the policies that we build every day. For this, we also need to vote more, to be more active at the political level, and eventually help the transformation of health and care from our side and not necessarily from the top to each of us.
Thank you very much, Karina. I agree totally on the vision that is not just healthcare system, but it is the system, the social system. And that's why also in Almaty, we have developed a work stream on healthcare and economy of well-being. Thank you for that. Going to Juan, I think that the added value of the book that you publish is that relate the person-centered approach not just to one healthcare setting, but to all healthcare settings, including the clinical ones. In this system vision, can you tell us what is the real messages coming from primary health care?
Well, yes. As you mentioned, in addition to dealing with principles and methods in this person-centered medicine book, we use the majority of the space available and about 100 participants, experts from around the world, to deal with various settings and clinical fields, from primary care and family medicine to specialized internal medicine and surgery, and also public health and traditional medicine, to examine the challenges of implementing, understanding, and then putting into practice person-centered care. And this has been also been complemented more recently in our various regional efforts, such as the one in Latin America again, where building on the main message of Alma Ata, which now it is being in a way retranslated as integral care of all by all, to cultivate not only professionals and institutional participation to facilitate healthcare, but also the crucial role of individuals and communities in there. And not only in terms of self-care, but also particularly in that emerging concept of mutual or intercare, the involvement of persons helping each other, which seems to be as old as Neanderthals to try to maintain our health. And that seems to be very crucial to also understand healthcare in a broader way, including social care, as our panelists have just said, and that way be more effective in approaching more fully the various challenges and opportunities that to enhance the well-being of all such an approach may offer.
Thank you. Thank you very much, Juan. Let me say that I love this vision of integral care. Thank you for that. And having this vision, Carlo, one of the maybe principles is to pass from a reactive to a proactive approach in healthcare. And a key element could be a multidisciplinary team. Can you just share with us your vision on that?
Yes, I think that person-centered healthcare is linked with the practice of proactive medicine as opposed to waiting medicine, which represent an important piece in the work against the chronic disease pandemic. When we address communities and individuals with a proactive plan and attitude, we want the involvement of citizens with lower economical income and education who rarely undergoes the necessary diagnosis in the presence of symptoms and with greater difficulties in taking care of their health. This evidence, constantly reported in all statistics, is the basis of a profound inequality of access to health systems, and it penalizes the weakest part of the population. If health systems include this share of individuals with the widespread proactive healthcare programs, it is reasonable to expect a clear improvement in the general level of health and probably a saving in economic costs. On the other hand, we know that the greatest health complexity derives from the interplay between social frailty, disability, and illness. It is therefore clear that a single professional is powerless to deal with this type of situations. This evidence is so easy to understand, but we still perceive a widespread resistance to a multidisciplinary working model from a part of healthcare workers and managers. The reasons of this behavior are so complex that can be the title of another talk show like this one.
Thank you, Carlo. Yes, of course, we could speak for days about this concept, and thank you for sharing your vision. Going to the last one, to Claudia, I would like to ask you a question that is a bit provocative. So we are citizens or we are patients? Because sometimes when we speak about person-centered care, it's just, okay, let's focus on citizens because of their skills, because of the characteristics, and it is not focusing on illness. But it's true that speaking about person-centered care, we have to think to the life course of individual with different needs in different moments, in different contexts, also when we need acute care. So can you give the end word to this talk show with the vision of your organization in relation to this comprehensive approach of patient, citizen, and healthcare system?
Indeed. Yes, thank you for the provocative question. I think we often hear that, we will all become patients at some point. And I think, of course, if it motivates us to build better healthcare systems for the future, why not? But at the same time, we do have to recognize that patients have specific needs and they need to be heard and addressed right now by healthcare systems. And that's the reason to make healthcare systems better right now. And of course, carers and families are part of the equation as well. So I really enjoyed this discussion, the importance of integration of care, the importance of this multi-stakeholder approach. And I will finish, Karina mentioned the elections. We do want to make sure that patient involvement is on the agenda for the next European elections, and that patient organizations who play a role in representing and helping the patient voice can really truly participate in healthcare policy and are truly part of these discussions on better healthcare systems.
Thank you. Thank you very much, Claudia. We are running out of time, so for my side is just to thank the panelists. Thank you for accepting the invitation, and thank you for this really inspiring discussion. And I invite you all to join our deep dive session now. As I said, there are one in Russian, one in English, and the link is posted in the chat. Give your insight, questions, and also present your experience in the deep dive questions. When you will leave the talk show, you will receive a pop-up with the survey. We ask to fill it, the survey, because we would like to have your evaluation, but also your vision of what you would like to listen in the next episode. So thank you very much again. Thank you very much, and see you soon.